Good evening, good evening. We'd like to welcome you to this another CGI podcast. The theme and subject matter of this podcast is DBH on the front line, serving communities of color. My name is Dr. U. Grant Baldwin Jr. I'm the Assistant Director of Academic Programs at Cummings Graduate Institute of Behavioral Studies. And tonight we have a stellar cast of DBH candidates who are matriculating through the program. And we want to have a nice, candid conversation. And again, the topic and subject matter is the DBH on the front line, serving communities of color. So we will start this off with some introductions. I'll first introduce Ms. Jennifer Williams-Madden, PMHNP-BC. She has a lot of letters behind her name. Jennifer is an adult psychiatric mental health nurse practitioner who has served in the mental health field since 2007. She has experience treating patients with various psychiatric disorders across the lifespan and across practice settings, and also enjoys her teaching roles. She currently works full-time at a community mental health facility as the medical director and provides direct patient care and also provides outpatient service at her own private practice. Jennifer strives to provide a holistic, individualized, personalized, and comprehensive experience for every patient she cares for. Jennifer, welcome.
Thank you.
All right. Our next panelist here, Ms. Rhea Hill, LPC, provides counseling for adult individuals with depression and anxiety. Her areas of concentration include women issues, codependency, self-esteem, domestic violence, stress management, and relationship issues. She is licensed in Texas and has practiced counseling for 8 years. Welcome, Rhea.
Hello.
As I see, you also make sure you put that DBHC on there because you are a candidate, right?
Yes. I put it on there, right?
Right. You got to, it's yours. It's yours. Our next panelist is Commander Sean Bennett. Sean is a behavioral health clinical consultant with IHSC BHU and works out of the San Diego field office. Prior to joining the team, Commander Bennett served as the behavioral health team lead at Otay Mesa Detention Center in San Diego. His previous assignment was with the Indian Health Services headquarters in Rockville, Maryland, where he worked as a public health advisor in the Division of Behavioral Health. At IHS, Sean served as the domestic violence prevention, served as the Domestic Violence Prevention Initiative program official. Also for the Methamphetamine and Suicide Prevention Initiative, Nashville Area Project Officer, and IHS National Lead for Zero Suicide. Commander Bennett holds a master's degree from the University of Maryland and is a licensed clinical social worker and holds a board certified, he's a board certified diplomat. He has worked extensively in the areas of substance abuse, domestic violence, suicide prevention, and the treatment of trauma. Commander Bennett is a member of the HSO Operation Corp Strong Suicide Prevention Initiative, also the executive officer of the SAT 5, also the lead facilitator and adjunct presenter for the COTA, Cultural Awareness Module. Sean, welcome.
Thank you. Thank you, sir.
All right. You have a lot of credentials behind your names. A lot of credentials, a lot of experience. Our next panelist is Jerrika Henderson. Jerrika joined the DBH program at CGI after obtaining a master's in clinical mental health counseling from the University of Memphis. She currently works on a specialized team as a community therapist, catering to underserved youth and their families, where she provides in-home intensive intervention treatment as a way to decrease inpatient and residential admissions. Ms. Henderson is devoted to being a change agent, proactively providing support to all through the facilitation and organization of groups, therapy, trainings, and events, all centered around subject that promotes well-rounded health. Ms. Henderson believes that through our commitment to a lifelong learning and collaboration with people from all walks of life, we are able to share ourselves with the world. She aspires to continue creating and normalizing mental health and behavioral health by providing a safe space for underserved communities. One thing Ms. Henderson wants everyone to always remember is that you may be bruised, but you are never broken. Welcome, Ms. Henderson. Thank you for joining us. Our next panelist is Mr. Napoleon Harrington. Napoleon is a licensed professional counselor practicing clinical mental health at Ambassador Counseling and Resource Group in the metropolitan Detroit area. He also serves as the vice chair of the State of Michigan Board of Counseling, appointed by Governor Gretchen Whitmer. Napoleon is currently completing his doctoral work at the Cummings Graduate Institute for Behavioral Studies. He's a husband to Faith Harrington and father to two twin 2-year-olds, Isabella and Imani. Welcome, Mr. Harrington.
Proud to be here.
But I want to introduce Ms. Shadiase Jack. Shadiase Jack is a LCSW-C and is a staff therapist at an outpatient mental health agency where she provides mental health therapy to children and adults. She willingly accepts challenges and pursues everything possible to bring speedy and workable outcomes. She embraces difficulty with the fist of courage, determination, and determination and strong will as failure is not an option. So, Ms. Jack, thank you for joining us this evening.
Thank you for having me.
As I'm reading through the credentials, and I have to give all of you a salute. You spent many years in school and then practice with all these credentials and serving in different capacities. With this subject matter that we have tonight, we felt like it was important to have this conversation. And this conversation is based on DBHs on the front line serving communities of color. And as DBHs who are people of color, our conversation at times can be very different than our peers. But also, with your expertise that you're bringing in the field and the skills that you're learning through the program, you're getting ready to step into the integrated healthcare field, being disruptors in healthcare and improving healthcare with all the skill sets that you need and resources that you need to make that impact. I'm going to start tonight's questions off with, I will start with Ria. And what medical behavioral issues have you noticed as a clinician in underserved populations of ethnicity?
Depression is one, and it's usually because of their finances or, the security of their foundation. So they may not even be able to continue therapy because of those finances. So that's very depressive. And there's also a stigma associated with coming to get therapy. So sometimes that's a struggle mentally in therapy when they come in. Yeah, those are the two things I notice the most.
So why did you think there was a struggle? There's a struggle.
Well, they're struggling in therapy because of the stigma. Stigma of people of color going to therapy. You're just supposed to wear the S on your chest. Okay. And bootstrap it. Okay. Suck it up and keep going.
Okay, I heard
That's
that.
A struggle. They struggle with that. Should I just bear and grin it? Or can I say that I have a behavioral health problem, but I'm having a mental illness or I'm not doing well? We can't really say that in our culture.
Right.
You just bear and grin it and get through it and everything will be okay.
Significantly, when you say a part of our culture, I definitely agree with you. We're dealing with generations of trauma dating back to the states of slavery and the impact of slavery. Yes. And, when I hear that, you say that, it makes me reflect on, one of the biggest things I know is that people in underserved communities is a faith-based initiative that helps support that resiliency and to try to look beyond the circumstances of all the social detriments that are there. And, we've become so strong. And so, we'll make, out of lemons, we'll make lemonade, That's what our people do. But also the thing that I recognize is that our strength can also be one of our greatest weaknesses as well, because we're so strong and we don't, as far as putting ourselves in a pathway, as far as to actually stop for a second. We've been on survival mode for so long, when it's time to stop and really start address the issues that are plaguing our life, and that continues through, like a pathology. We struggle with that. So thank you for bringing that content up. Ms. Jack, I'd like to pose the same question to you. What medical behavioral issues have you noticed as a clinician in underserved populations of ethnicity?
Okay, so with the population that I see, again, piggybacking off of Ray, a lot of depression and also ADHD in boys in the community that I see. A lot of them are classed as just being oppositional and not taken into consideration that they may be having ADHD. Also with the depression, a lot of my teen girls who have depression, they're just misdiagnosed as, oh, well, y'all just have an attitude problem. And so that I think is part of what kind of keeps us back, because then it kind of leads into that stigma of angry Black women. Yeah.
Okay, that's a great point. I definitely concur with that. Thank you for sharing that perspective. And you're located in what city again? You're serving in what city?
I'm in Southern Maryland.
Southern Maryland. And I'm sorry, Rhea, I should have asked you this as well. You're in Texas, correct?
Dallas, Texas.
Okay, Dallas, Texas. So we're dealing with the different regions around the country right here. All right, Mr. Napoleon Harrington. The question. Go ahead, sir.
Same. It's so interesting that the same issues are facing so many similar environments, and that whole conversation about the strength of African Americans being our greatest point of pride. It's also been, as you mentioned, Dr. Baldwin, one of our greatest struggles, because we've been able to be viewed as very resilient because everyone considers us to be as strong. But the truth is, we are people too. We're just, we're human. We've got capacities, we've got limitations. And what I've noticed within practice, my way, I've been diagnosing more consistently adjustment disorder. And that's, of course, a lot considering the pandemic, et cetera. I've seen a very high incidence of high blood pressure among African Americans, and there's tons of literature out now that's basically suggesting that since 2020, we've seen a significant spike within people of color for high blood pressure. Well, of course, pandemic does give us a little bit of that insight, but there's so many things that kind of that contribute to that. Also, I've noticed a very high incidence of strokes, and not only strokes, more heart problems like atherosclerosis and a few other things. So those have been some significant things in more recent times that are on the table. And we can't forget diabetes as well. They almost come as a big three: high blood pressure, diabetes, and sometimes stroke and heart problems as well. So there's a lot of things that have been significantly facing us since pandemic time.
Well, thank you for sharing that. And as we speak about the medical behavioral, we notice that, one thing I've recognized that people are not dying of mental health disorders. They're dying by the medical conditions that are being exacerbated by the mental health disorders that are not actually being treated. There's evidence-based pieces that if you're able to effectively treat the mental health disorders, it's a great chance of improving the health outcomes and the quality of life of the patient. So I appreciate you for bringing that up. So, as DBHs, we deal with the medical and behavioral, aspects of care. So thank you for sharing that. Let's see the next person I have here. Let's see, this says Sean.
Yes, sir. Yeah, very much agree with all of the previous speakers. Working for the United States Public Health Service, I often work in across many communities of color, and just sort of in an umbrella term considered BIPOC, Blacks, Indigenous, and people of color. Right before joining Immigration Health, where I work now, I worked for 5 years at Indian Health Service, and clearly in that community, two things that were extremely problematic in terms of it really being at epidemic levels, and that is alcoholism and suicide. And not unlike our African-American brothers and sisters in terms of sort of the stigma that's associated around mental health in general and suicide in particular, that creates a gap in terms of accessing care. And I'd like to draw the parallel as well with our community, African-American and Black communities, is that a palpable level of distrust that we have for health in general. And there's historical reasons why we would be in that regard. So, but those are two conditions that I've seen in the Native American or American Indian Alaska Native community. And of course, in the Black community, all the things that we've talked about. And just, I just like to emphasize just how challenging and difficult it is for Black people to even come to the table when it comes to mental health, in part because of the distrust. And like you said, Dr. Baldwin, that the additional stress that we endure because we don't get it treated exacerbates the physical conditions that we have as well, which are too numerous to name, but yes.
Okay, thank you. Thank you for sharing and that perspective there, Sean. Okay, let's go to Ms. Jennifer.
Yeah, so of course, being a nurse practitioner, I see a lot of comorbidities with the physical and mental health. And, I always try to educate, my patients, if you're not sound mentally, then you're not going to be taking care of your physical health. And a lot of things interplay with one another as far as mental health and physical health. And I tell them, undiagnosed hypertension, can lead to chronic depression and anxiety, thyroid issues, obesity, like all of these things that, go undressed, go under the radar, are exacerbating their mental health symptoms, and vice versa. And so, with a lot of people, in the minority communities, they already have a barrier to wanting to access treatment in the first place. And so those issues are creating exacerbations in both areas, both in the mental health and in the physical health. And so honestly, part of what I wanted to do with this degree, as well as a nurse practitioner, was try to bridge the gap there and be a warm, welcoming face for people to want to access care. They're more likely to access care if they see someone that kind of looks like them. And that's been a lot of the conversations that I've had over the years that I've been doing this, is that I'm so glad I have you, because I've never had anyone that looked like me, that I felt like I could connect with, and that would actually understand where I'm coming from. And people have stuck with me over the years. They've found me if I've moved places, because they, enjoy that connection and that bond.
Okay, thank you. Thank you for sharing that. Thank you. All right, going on to our next question. How important is it to have DBH clinicians of color involved in integrated healthcare and innovation? Anyone feel free to speak here?
Again, it kind of goes back to culture, because I can tell you, I've had a few people come into therapy and they come in blindly because maybe they got my information from their EAP, they don't see a pic, maybe they didn't search, and they say, I'm so glad that you're Black. Like, I'm quoting. So they're comfortable with talking to someone who will know our culture. And that's what I get a lot of that. I get quite a bit of that. So bringing that into an integrated care setting helps the client become more, or the patient become more comfortable, builds rapport and trust. And then they can be honest enough when they let down their barrier. So when me or anyone else who's in that integrated care goes and speaks with a practitioner or a doctor about what that patient is experiencing, it can be more honest. And you'll get more clarifying information to treat the patient. So with the bridge there.
Okay, thank you. Thank you for sharing that. Anyone else like to chime in?
I can answer.
Mhm.
Can you all hear me okay?
Yes, we can hear you.
Okay, so I would have to say that I agree, and I think that it's very important for people of color, especially African Americans, to be in the room with patients who look like us. Once again, for them to see that someone is on the other side advocating for them, being a change agent for them, I think is very important that when we go into healthcare settings, whether it be a primary care, a specialist, or even for therapy, we're able to see someone in the office that looks like us, mainly because over time, we haven't been able to trust our providers. And just being frank, we are overly medicated, diagnosed with some things that we don't have, undiagnosed with some things that we do have. And I think that when I go into a doctor's office or any type of facility, seeing someone who looks like me, I have more faith in the business. I have more trust in the business, because if they will hire someone that looks like me, they care about me. It also gives me the opportunity to talk to someone to say, well, what are some questions that I may not think of that I should ask the provider? Or what are some things that you think should be done differently? So my main thing is having someone, or us being a person that can advocate for our clients, both while they're in their appointment and while they're gone. So I think it's very important that we communicate with the providers we're working with. We communicate with the clients that are there so that they know someone cares about them and they should continue seeking care. And it's never too late to turn any type of diagnosis or disorder around.
Powerful statement. Thanks for sharing that. Everyone's just chime in. Let the spirit of the DBHs move you.
Just to add another layer on what Jerrika said. Also, when you have people from the immigrant community that comes in and they recognize, oh, this person has an accent that's similar to mine, then they're like, well, where are you from? And it's like, oh, I'm from XYZ. Oh, okay. So it provides another layer of trust, because you're familiar somewhat with the extra layer of stress that is immigration. Okay, because I'm still going through that right now. So there's that as well.
Okay.
Yeah, and I pick up on that note to also dovetail off of what Jerrika mentioned, and also connect to what Jennifer mentioned earlier. Jennifer gave us a really real-time experience in terms of how invaluable her presence has been to some of her patients in terms of them seeking her out. And then in terms of what Jerrika mentioned in terms of communication, communication, we know, happens across many dimensions. There's verbal communications, there's nonverbal. Sometimes you'll walk into a place and you can just look and you can get a whole lot just by looking. And if you look and you see somebody in there who looks like you, that can communicate a lot. If you don't see anyone that looks like you, that communicates a lot. And so that communication is very vibrant. And I think having the presence of folks, people of color, who share similar cultural leanings, and having someone who has and certainly we know that people can evolve to see things from a culturally informed perspective. That takes time, but when you come to it naturally and organically, that means a lot. So yeah, it has a great impact.
Right. Anyone else want to chime in or piggyback off that before we move to the next question?
Well, I kind of think it's really ironic that if you notice, even in the panel right now, all of our chins have come up and we're smiling because we're listening to what our colleagues are saying about each other and how our patient experiences are and how we represent ourselves in our particular areas. We're proud of each other, and some of us just met each other. And so it's exciting to just listen to the conversation. And so to transform that conversation into what happens when someone who looks like us or who might have a different shade than us walks into our offices and says, wow, they feel a sense of pride and acceptance and this idea of I will be heard and I will be seen. And so not only as a DBH do you bring some level of hope, but being a DBH of color, you bring hope within hope. And I think that that's a really exciting opportunity. So I'm feeling my heartbeat fast as I'm listening to everybody talking. I'm like, oh yeah, these are my colleagues. You know, it feels feels good to hear you. So yeah, it's happening right here in real time as well.
And I definitely agree with you about the impact of our patients, and all of you, what you said about our patients seeing us. I mean, that's happened to me as a DBH. A little exposure there. And if you look at my name is Ulysses Grant Baldwin Jr. So when folks see the name and then see me in person, is a totally different scenario of warm wishes. I've received hugs. I've seen tears. I've had situations with that, with the pride of seeing one of us looking there, and they'll tell me, I wasn't expecting you to be Black or of African descent or any of that. It's immediately said. I've had that happen several times and still do. So, you know, once it was interesting, they'll tell me once they saw the name, they just did not think I was, you know, someone of color. And of course, you look at my name, you would tell that it doesn't signify that, though. But that's I'm glad that all of you are pointing out the importance for and the impact that just in our own ethnicity, the impact that it has.
Can I also add?
Keep adding. Let the spirit move.
It's kind of off topic, but related. And I will say, like, joining this program and having my interview with you and Dr. Young, I was pleasantly surprised that you guys were both African American. And I feel like that has created more, comfort for me being in this program. I feel more supported, and I feel like you guys are better able to articulate and help all the program, and all the students understand, the importance of inclusion and making sure that, representation is occurring and helping them understand, the history behind why minorities might have a distrust for the healthcare system and whatnot. But I just want to let you know that I feel very supported and very pleasantly surprised and happy with the program and with our mentors and our professors. So
yeah, it was great. I mean, when you all come forth, it warms my heart to see someone that looks like me.
That leads to another discussion. I'm just curious. I don't know.
Right. Well,
we don't have to take an official poll, but I wonder, and you feel free to chime in if you want, how many people went to HBCUs? And the reason why I asked that is because I think that's an important initiative. I recently, me as well, right? Undergrad. And so I recently did a presentation to help raise money for HBCUs. And there's been a lot of focus and attention paid on that. And the reason why I bring that up is because there's a gap in the pipeline of recruiting behavioral health professionals in general. And certainly you talked about how small, Dr. Baldwin, the number of that we represent, in the larger scheme of things. And so I think it's important that for me, having gone to an HBCU, you have that experience. And Doc, you and I had a bonding moment early on, but to Jennifer's point, when I first interviewed with you, and I realized that, we probably hail from very similar backgrounds. It really did give me a sense of, okay, I got this, I can, I feel comfortable. I know that he's going to hear me and listen to me. And I think for me, coming out of an HBCU and then going to a predominantly white grad school, I felt like I was equipped. I felt like my family embraced me and sent me off into the world, so to speak. I know that's kind of corny, but, I think having that, then I start to look for other folks who look like me to try to recruit them as well. So I think, and however we come by that sense of racial pride and the importance of our heritage, I think that it's incredibly important for us to each one teach one or reach back and be that inspiration or influence to help other people move in this regard as well. So thank you to you, Doc.
Sean, I thank you for bringing that up, see, because once you said HBCU, I saw faces light up and I saw just the body, start twerking and moving a little bit because there is great pride. And I don't want to make the same mistake I made earlier. So please name the HBCU that if any of you attended the HBCU, please name that HBCU.
Bowie State Bulldogs.
Bowie State. It's okay. Bowie State.
Bowie State, Maryland. Yes.
Bowie State, Maryland.
Yeah.
I attended the University of Arkansas at Pine Bluff, known as UAPB, and I am a proud member of Delta Sigma Theta Sorority Incorporated. So I also want to say, Sean.
You could throw it up. You could throw it up.
I can, and I will.
This is us. You know how we do.
So, and I think anybody and everybody who has interviewed with you will say that they have a special bond that happened in the interview. And after being accepted, I believe that bond grew, because I know we had, I was nervous. I'm like, I am too young to be applying for this. What am I doing? I've never been nervous in my life for something. And when I saw somebody that looked like me, I was like, okay, nerves are gone. Answer the questions. I know the answers. And it came naturally, and the connection came naturally. But to that point, I also want to say, yes, I went to a HBCU for undergrad, but then for my master's, I did go to a PWI. And we're talking about being equipped to help people of color. But I just want to say that it's amazing that we are in this program to be change agents, not just for people who look like us, but I have a sense of pride when I step into a room and my clients are not Black. They don't look anything like me, and they cannot understand how am I the one that's going to be helping on their treatment team. And I'm also the one that's providing the most care, because at the same point, we care, not just about people who look like us, but about everybody, because we want them to receive treatment. So I just wanted to add that in.
Okay, absolutely. Well, you added it in, and since you represent, I'm a proud member of Alpha Phi Fraternity Incorporated, the first of all Black Greek fraternities. So I think there's another fellow Alpha man here. Another fellow Alpha man here.
No.
No, okay, never mind. We'll talk about that later. All right, family, we're getting ready to move to the next question. All right. How do you see yourself as a change agent in healthcare? So just please chime in, everybody. We're having a conversation like we're at the house.
Well, I think Jerrika kind of got us rolling in that regard. Right? This is a unique opportunity and very exclusive. And when, even in what we're doing now, it's just listening to everybody's bios in terms of what they're doing. They're already change agents. We're already change agents. We're moving mountains, right? But as we continue to matriculate through this program and eventually our, DBH ourselves, it's just being in the room. There's that book, I think it was written by one of the Joint Chiefs of Staff, and I'm sorry to it was called Being in the Room. And then they're talking about these high level conversations that are being had. And just having people like ourselves in the room when important medical decisions are being made across the board is going to be really important. And when people see us, when they see people of color, then we start to also change and shift the narrative in terms of what people expect and know about us. They're not just seeing us as athletes and entertainers, but they're seeing us as people who can, in fact, influence change.
I definitely agree with you, Sean. And I think being in the room as well as being in the community. So to me, a change agent means being an advocate for myself, for everybody. So that means stepping outside of the offices that we work in, stepping outside of the community that we work in, but going to places where people haven't heard what it means to receive care. Doing that outside, hosting events, at places our colleagues would not normally go. And sometimes that means going into the neighborhoods that nobody wants to go in, but we want to reel them in. We want to bring them back in. So change agent, basically, for me, it just means being an advocate for all.
Absolutely. Thank you for sharing.
I'm trying to change a whole country, so
okay.
trying to go back home to work on that stigma of mental health back in Trinidad and Tobago. So it's just like, all right, so I have a whole country and probably a whole Caribbean region that I have to go tackle. So it's preparing me to go do that, because whereas mental health here is stigmatized, it's not as stigmatized in the US as it is in the Caribbean, because in the Caribbean, oh, you're doing that, oh, you crazy. That's it. they don't even want to touch it. You crazy, that's it, whatever. So that's what I'm trying to do.
Yeah, and I would just ask you, should pronounce it as Shadiase?
Shadiase.
Shadiase, a lovely name.
Thank you.
And I'm always recruiting, right? And I know you're a fellow LCSW, correct?
Yes.
And so, yeah, there's a lot, we do have a higher percentage of Blacks who are LCSWs than psychologists, but that is the LCSW, the MSW is a terminal degree by which you can apply your trade across many systems. I want you to consider to do that. You talked about impacting the world, which we will all, which we are to some extent, little by little, but certainly consider the United States Public Health Service. And they didn't pay me for this unpaid advertisement, but I say that because it gives you an opportunity to work across so many different domains, and having that degree, and certainly having this degree, would make you even more invaluable to make that change. And most of the work we do it exists in those BIPOC communities, where access to healthcare is limited, and so you'll be a shining light. But wherever we use what we learn as a part of this process, I know that we will all be able to influence and shape, disrupt things. I like that the way you guys refer to that, to be disruptors. That's wonderful. We have to shake it up, right? Shake the system up. So
call it out. Call it out, and definitely. So thank you, Sean, for that chiming in. And Shadiase, we are very excited about the work you're going to do at your native homeland, where there's many people of color that will be impacted by. So I look forward to seeing all that progression. I also look forward to you inviting all of us over and flying us over to work. Well, I had to throw that in there, So, we'll come and work. We'll come and shake it up with you. We'll come in there.
Let's go. It's going to be a DBH party.
All right, let's do it. Let's do it. Anyone else want to chime in on that? As far as questions, how do you see yourself as a change agent in healthcare? So we know that we're changing in the United States. We're changing in Trinidad and Tobago's, all over the world. How do you see yourself as a change agent in healthcare in your area or in what region part of the country that you're in?
Well, change is an inevitable part of life. And if we consider ourselves change agents, that means we're the ones who are initiating the inevitable. And so with that being said, we literally are the people who will come in and be the emotional champions, the developmental strategists, the intuitive adapters, and the continuous improvement professionals who are all focused on making sure that we provide care in a way that is meaningful and sensible across the spectrum, particularly for underserved and underrepresented populations. Change is one of those things that, of course, it makes people uncomfortable. So we're not going to be the people who will always make people comfortable, because change requires some really difficulties, right? So it takes a lot to have to make that change. And so as change agents, we're accustomed to being those folks who explore that kind of level of innovation and address those challenges.
Great deal. Appreciate that, Sean. Anyone else?
I think everybody said what was on my mind, and Jennifer started it out by saying inclusion. Being a woman of color, yeah, when we come into the room, that means inclusion and diversity.
Mm-hmm.
Yeah.
And the definitely inclusion and diversity. And the thing that I look forward to a lot of your work too, dealing with some of the trauma and the pathology and the generational trauma that has been that's embarked upon people of color in underserved communities. So I definitely look forward to your work there, and all of us collaborating together to support you.
Yes, and I want to see more. I want to see myself go more into, as I've said before, equine therapy, which is another area that's overlooked and definitely underserved in the Black and the Hispanic community. Those horses are healing, and we can benefit from that as well. But when I walk into the ranches, I don't see us. So that's where I want to put my change.
So you're going to be the pioneer in that, introducing us, to
need to be
that.
included. Yes.
Hey, hey, all willing to learn something new. So, I will make a trip. I want to see what it's about now. Get on the horse or something. I don't know, but definitely. So I'm very excited about that. Very excited about that. Anyone else want to chime in? And how do you see yourself as a change agent in healthcare? All right.
I think can I throw a proposal out, Doc, in terms of that?
Go ahead.
So Ms. Jack was talking about, sort of how in the Caribbean, it's even more stigmatized around mental health. And not that it has to happen there, but it would be great if we could have sort of a symposium, even as students, where we can all contribute to the things that we have worked on. And some of us are more advanced, like Napoleon, I'm sure, in our studies. But wherever we are all making a difference right now. Is that something that we can look towards maybe and help to, maybe if you can champion or help to organize and helping us come together maybe in a symposium some point down the line where we can talk a little bit more about these things and expand it and raise the level up in terms of the importance of diversity, equity, and inclusion, and the importance of being change agents in an era that is both changing exponentially, but also seems to be regressing, if you know what I mean. I mean, if you look at the political landscape, certain things are on the horizon that may suggest that we are not as a country, not as a whole, progressing as much as we would like. So while you have maybe a preponderance of people who recognize the importance of DEI and things like that, you do have, it seems like, I don't know how formidable it is, but you do have a contingent, an undercurrent that is sort of pushing against that. And so, we can't wait until we graduate. We have to start, bringing our minds together and making proposals to how can we influence that change, even as we are changing and becoming, professional DBHs, if you will. Just a thought.
Oh, that's a great and powerful thought. And actually, that was the intention of this happening. It was more than just a podcast to create this conversation, because this actually is one of the first unique conversations of dealing with ethnicity as far as people of color at CGI. So this was the initiative. You probably know that, but this is going to be a series, and that's going to broaden and the conversation and increase, our awareness and, awareness to our communities. About all of the issues, all the social detriment issues that are impacting us, policy, just a whole array of things, all the barriers that are prohibiting people of color and underserved communities for accessing quality healthcare. So, Sean, you're right on it. So welcome. You're in it already.
Awesome. Great.
Good deal. Good deal. Thank you for bringing that up. Oh,
and that is taking place in the Bahamas, right? Did I miss that?
I thought I saw that. Was that the memo? Yes. Southwest, please.
Yeah. Yes.
Get my 2 bags.
That's gonna be our inaugural one, right?
That's the inaugural one. Right. You smiling? We serious. So, but anyway,
gotta get the planning, right, Doc? We got to get the planning.
That's what I'm saying.
Memphis would love to host.
All right. Let's make it happen. All right, moving on to our next question. And everyone feel free to chime in on this piece here. Do you think the engagement of healthy behaviors has the potential to prevent or reduce morbidity and mortality that plagues the African-American Latin community? If so, please explain.
Yeah, for sure. I think it's our 9902 class. We had a project to create a group. I believe it's, and I maybe get that's the right group. Yeah, that's the right class. We to create a group around an issue or comorbidities, if you will, right, in whatever community that you're in or any community for that matter. And the project, and it's not surprising that here, and I'm in San Diego, that the same issues that plague the community at large, plague different sectors of our country. And here, things like obesity, cardiovascular disease, diabetes, those are some of the things that become prominent. So I propose doing a group around what I call 12K, 12V. So 12,000 steps, increasing physical activity, and 12V is trying to diversify your diet to include new vegetables. And there's studies that show, as you increase, the variety of vegetables that you eat, obviously that's going to have a healthy outcome for you. But just this is just something that I did for the project in the class. But clearly, when we think about the kinds of issues that plague communities of color in particular, they're very much focused around certain behavioral factors that lead to conditions that beset us. And so absolutely, and I'm sure my colleagues, I read some of the posts, and I've seen like with Jennifer's posts and, Jerrika's posts in particular, and I know that they're focused on very similar things. So absolutely.
Thank you. Great points there.
And I would add that preventative care is really key to reducing, morbidity and mortalities to these chronic health conditions. So as Sean is saying, teaching them, ways, healthier ways of eating, increasing their physical activity can all lower the chances of them developing, or if they already have it, we can reduce the morbidity associated with those disorders. But we kind of need to do a little better job of reaching these communities. And unfortunately, we still come back to our, first original, discussion of what are the barriers to accessing care and, this trust for the healthcare system. So we got to figure out ways to better reach these communities so that we can employ these ideas and these interventions to promote more healthy behaviors and reduce these tragic rates of these chronic health conditions.
Absolutely. Thank you for sharing. Great points there.
Jennifer, absolutely. Oh, go ahead, Rhea.
I want to. You can go ahead. I want to say, let me add that anything that we focus on grows. We've heard that before, right? If you put your attention on it, it grows. So we spend a lot of time on social media, and whatever we're accessing, we're helping to feed our brain with that. So, but if people, Hispanic people and people of color and Black people saw more healthier images, more often in those positive roles of being healthy, then that's where our attention will begin to grow. So yes, slowly but surely, morbidity rates will go down and all the unhealthy things will go down, but we just have to see the image in order to be the image. I want to add, that was my answer to that.
I had great points there. Thank you for sharing.
So you just kind of about-faced some of my comments, and I'm glad you said that because it's interesting. I read a lot of work from times past, W.E.B. Du Bois, Booker T. Washington, et cetera. And one of the biggest concerns has always been that we have not been able to control, people of color, that is, control our image in any sense of media. So of course, as time progresses, whatever form media takes, if we don't have meaningful consultants there to show them, so this is what we look like. And DBHs need to be consultants with media to say, this is what healthy brown folks look like. And they go, oh, so eating more vegetables and being more mindful. Oh, routine screenings. That's what you want us to promote more information about. Okay, that is, which really seems very obvious, but you've got to be at the table to be able to do so. So to Jennifer and Rhea's point, prevention is much easier and less costly. And if we've got DBHs as consultants in the right arenas, to Rhea's point, then, and especially social media, which we have a paradox of progress because social media has overtaken our lives in a way that we don't want to admit. I read something in USA Today not too long ago that said we consume as much social media that it's the equivalent of a part-time job.
Yeah, I can
like the equivalent of a part-time job. So it's just amazing. So to that point, if we're able to put appropriate representation at the table so that the presentation of self in the media looks better, then we will do a remarkable work.
No doubt. That amen. Let's go to church here. You're right. I mean, and when I think about, you talk about, the notion of disruption and being disruptors, but also being change agents, but also focusing on integration. And I know when we had a project in 9901 to create a website, a blog. And I was looking for an image to create on a blog to be the brand. And it was a concentric, three overlapping circles, like a Venn diagram. And it's three eyes I just want to talk about. It's the inspiration, kind of like what you're talking about, Napoleon, that we have to be people to inspire. Innovation, we have this important media platform, or these media platforms, and integration. And so bringing these things together to influence that change is certainly very much in line with what certainly I aspire to do. And I think that we all aspire to do, which is the reason why we're here. We all are, fully professional in our own right, doing what we're doing and doing well at it. But there's something more. And I think you touched upon it in terms of what we want to do, but also what we can do. So awesome.
Awesome points. Absolutely. Absolutely. Anyone else? All right. We're going to move to the next question. But before we move to the next question, Ms. Rhea Hill has another obligation of psychopharmacology as a DBH student. Rhea, we thank you for participating with us, and be prepared for this to be a regular thing when we have our conversation. So we look forward to hearing from you.
Thank you. I enjoyed it. I will talk to you later. All right.
All right.
Thank you, Rhea. Doc, one alibi really quick. I think I have another class too. Do you give hall passes at all?
Well, you can definitely hall passes, especially for class. I mean, this is the life of the DBH. You guys are squeezing in this time to have this conversation with me, but that's a very excusable pass to exit the podcast.
Yeah. No, I know my classmate here. I know she and I, we had to join that class, but I think two of us. You're in the class too, right, Jennifer? I think you're in the, oh no, you're not. I know Jerrika and I are, but in all seriousness, I mean, we obviously will transition, but we wanted to be here and just hear this conversation. I'm glad that we were part of it. I mean, hearing all of the bright minds and the bright ideas and the bright impact and the bold impacts that everybody's making has warmed my heart. I'm inspired. So
I feel more inspired as well. I was going to say the same thing.
Yeah. So
yeah, definitely. So thank you very much. So both of you have your classes. So
I am so inspired that I'm going to stay on the podcast. I have already emailed my instructor and let her know I would be a couple of minutes late.
Well, look at, I heard that. You representing. Okay.
I'll sneak in the door behind you and just say I was with her.
Yeah, it was with her. I'll vouch for you. I'll vouch. I'll talk to Dr. Cummings and I'll vouch for you.
Okay,
right.
Thanks, Doc.
Anyone else want to chime in on that particular content on that question before we move on? All right, we're going to move right on. Next question. Can you please expand on the connection between mental health and chronic medical conditions?
I would say, like Jennifer mentioned before, like where they're both interrelated. So when I did my my research for my class with you last semester, Dr. Baldwin, where I focused on diabetes and chronic depression, there was literally, I can't remember off the top of my head right now which one of the researchers found that people with depression experience their symptoms of diabetes are twice as worse than somebody who does not have depression. And I was like, wait, what? That was my thought when I was doing the research. So when I saw this question, I was like, oh yeah, absolutely, definitely, I could see that. So it's like that vicious cycle of you can't ever, you're like a hamster on a wheel, you just can't get off of it without dealing with the mental health piece of it, like Jennifer mentioned at the beginning of our podcast.
Well, I'm glad you remember that from your class. You are a scholar. You did well. But the thing to it, I chime in on is you cannot disconnect mental health and medical conditions. It is linked into each other. One's going to have an impact on the other. And so I thank you for bringing that point out. And thank you. Let me know you still remember something from the course, Jeff. Scholar.
Yeah, for sure. We talked earlier about sort of historically and traditionally how certainly people of color and Black people in particular, have not had access to or trusted accessing healthcare in general and mental health care in particular. And not having an outlet to relieve some of that stress is certainly going to impact and exacerbate anyone's medical condition. Mm-hmm. Doc, you kind of described it as, us sort of, and I think Napoleon touched upon this too, our sense of resilience, which is certainly a source of strength, can also be a very real, detractor from that strength. And there's a physical condition known as congenital insensitivity to pain, right? It's like you cut yourself, you don't know you're cut. And literally you can die because you don't know that you're feeling pain. I'll propose that certainly that's something that we have psychologically, that we have built up such a hard shell that we're not recognizing how these things are psychologically affecting us, creating more hypertension, more stress, and other kind of conditions that ultimately end in our, bad negative health outcomes for us. So yeah, absolutely, they're inextricably linked. I think intuitively, we have known that. We have sought other ways to kind of get relief from that, some good, some not so good. But here we want to put the focus on, as we were all talking here earlier, helping people pursue healthy behaviors to help relieve and alleviate those things.
Great point there, Sean. Thank you, sir. Thank you, sir. Anyone else want to chime in on this? Expanding on the connection between mental health and chronic medical conditions. Well, all right, we'll move right along. Okay. Next question. How has the DBH curriculum impacted the communities or the patients you serve currently in your various locations of practice?
I'll start by saying, I'm sorry, I see you're about to talk. But I'll start by saying this program has impacted me as well as helped me and my colleagues. Everything I learned, I'm like, y'all, look at what I learned in class. Listen to this. We can add this in. So I feel like I'm better prepared going into sessions, and I'm able to help my families more with things that I learned in class and being in this program and from the readings, just based on the assignments we have to do, the readings we have to do. And I feel like it's a vital part of what we do. So we all have different backgrounds of what we're trained to do from our master's programs and what we're licensed to do, but collectively we're in a program to be a DBH. And so when I go out and I do my job, I'm not there just to do therapy. I'm there. Do you need a med appointment? Do you need transportation? Do you need an advocate? Do you need me to call somebody? What do you need today? And so it may look different day by day and client by client. But I think this program helped me to see that what I do in my job right now is not just therapy. It's literally being there for a person, however they need, whatever they need, and for them to be able to rely on me that I can help them get that care, whatever it looks like. So thank you for that, because I learned that from you.
Well, see, you trying to make a Black man cry live on the podcast. I don't front because we're recording, though. That touched me. Thank you.
Say a little more, Jerrika. Say a little more. Hurry.
See, look at see how they're trying to do it, brother. But I definitely. Thank you for bringing that up. Thank you. Anyone else want to chime in?
Great points that Jerrika brings up. And for me, what it's done is it's heightened my sensitivity to like the strategies that I'm using, and making sure that I'm using strategies that also are taking into account the biological concerns or the comorbidities. I'm normally just addressing the mental health from a general standpoint, but now I've become more of an all-around or all-inclusive practitioner, which which makes me feel a whole lot better about the outcomes that I'm getting. I can't say that they've been so significant that I can just, it's like revolutionize everything so far, but I can say that I've seen a difference in the way that people have responded in my clinical work, and so because of that, I'm more inclined to like dig deeper and go a little bit further into more of it. And so, especially with that the neuropatho course and the psychopharmacology, I took a psychopharmacology before, but it wasn't like this, and so it really helped. It really helped to like expand my awareness on how these interchanges interact. So it's been all positive for me.
Thank you for acknowledging.
I would like to add, I feel like it's helped me. Like I feel like the psych nurse practitioner and DBH are very similar in many ways, in that we are holistic in our care, and we already have a good understanding of the physical health as well as mental health conditions.
Mm-hmm.
But for me, I feel like the program thus far, and I'm only, my first year in, is that it's helped me kind of fine tune some of those skills that I've had, that I've already learned, and that I can kind of hone in on things a little bit better, a little easier. My time management of, working with individuals have greatly improved. So I'm actually able to spend more time doing the things I need to do with people rather than asking a billion questions. I feel like I'm better able to hone in on things a little quicker and try to get better results a little sooner. And I think that it's had a pretty good outcome on the patients I've been working with.
That's great to hear. Great to hear.
Yeah, it's like Jerrika said, and I want to dovetail on something that Jennifer said as well, but what Jerrika said about sort of the pragmatism of this, I'm just in my second semester, but I can tell you, real talk, that like what I do and what we learn are just so similar. Like we talk a lot about integration. We're literally trying to implement an integration program at work, right? All of those things. So that is very much relatable. And I know most of my nurse practitioner friends, psychiatric nurse practitioner friends and colleagues, they really do have a very broad perspective about that. And shout out to Ms. Jack. I know that like social workers tend to try to think in a very systems broad way like that. So it is helpful to kind of to see this program helping us to think about that. And like Jennifer said, but the focus of being able to be very efficient with your time, right? In terms of knowing, it's like if a person comes to us and we're only thinking about the psychology or the mental aspect of it, they say, okay, just leave my body at the door and bring my mind inside. Or conversely, leave your mind outside and bring your body. And right. So the DBH is helping us to understand and focus on, we want to treat the total person. And our role in that is so critical.
Great points there, Scholar.
I think for me, it's being able to actually use the Biodyne model and actually see it come to light. Because I don't know, Dr. Baldwin, if you remember that one lady from my first semester, I actually, still working with her, and still everything else that she has popping up right now is like, okay, how are you doing? What are you doing? How can we help you? She's like, I'm so tired, blah, blah, blah. And I'm like, okay, let's talk medications. And she's like, what? And I was like, yeah, let's talk because all your comorbidity plus your mental health, let's get into that conversation. Here's how the conversation that you're going to have when you meet with the psychiatrist in 2 weeks, and just being able to see how we put all the pieces together, see it happen in real time is what I think is.
That's powerful.
That's very powerful. And the Biodyne model, which is the bloodline of as far as the DBH, powerful, effective treatment. So, and I'm glad it's applicable in your practice now before you even come to DBH. So that's impact. So thank you for sharing that. Anyone else?
I literally just before this meeting, I was on another call and we were getting mentorship, and we were asked what goals were we working on, and somebody asked about. And I told them I was in the DBH program, and I was explaining to them why I chose this program after doing my research, and how I felt like it was so much more practical and pragmatic and useful And that's why I ended up choosing it. So I just wanted to reiterate that and thank you, Doc, and the school leadership and all you guys for creating this program. And I'm just excited. So.
Oh, absolutely. Listen, that's what we're here for. If you notice a lot of the curriculum, I noticed in my previous curriculum, I noticed that in my graduate, I went through Fayetteville State University. That's my HBCU. And, in fact, it was HBCU, they had a lot of focus on as far as people of color. And as far as my doctorate, it didn't have that much, so I went to a PWI, Arizona State University. It didn't have a lot of content dealing with at-risk populations. So if you realize in the curriculum, we really have some real hard conversations, some conversations that we probably didn't even have it in grad school on the doctorate level, dealing with some of the social justice issues. And other different social detriments that are happening. So we weave that into the curriculum because there's a great chance that we're going to treat people that look like us in underserved areas, even in urban areas. So that's very important. So to ensure that, the literature and the information presented is, from a population health standpoint, is focused on everyone, and especially giving some emphasis to those at risk. All right, anyone else? All right, well, this is the last question of the evening. Speak to the learning environment at CGI. What type of support have you received from CGI faculty and staff?
If I can jump in there first, one of the things that I think CGI truly understands and the professors understand is that we're working professionals with dynamic lives, and I know I probably get known for turning in a paper late a time or two. I don't know how many times, who's keeping count. Thank you very much. Thank you for the support. But very often, even though they still hold you to a very strong academic rigor, they understand that life isn't always convenient, and that you're able to, still submit papers. I had colleagues who are in other doctoral programs, and when it comes to submitting things that might be beyond the due date, some professors are saying, absolutely not, you can't do it. And what happens is they run into problems and then can't, they have to retake the class, which is more money. And but from the perspective of a working professional, it's great that all of our professors work in the field, so they understand that life's dynamic and that we need that support. So that I have to be the first to say that, because I probably am the biggest offender.
No, you're fine, and you're doing well, scholar. You're doing well. And the thing about it is all about the mastery of the work.
And I appreciate the mentorship that I've had thus far, and being you guys being so accessible to us. And like I said, just being able to be more, you guys are more relatable to me, that I feel like there's like an open line of communication always available for us, giving us your cell phone numbers, for instance, like that's the level of personableness that I've never had, like in any program I've ever been in. And my colleague and I, who's also in the program, but not part of this podcast, but her and I were just talking the other day about how much we are enjoying this program, and how so different it is compared to like the nursing programs we've been through over the years, where it was like cutthroat and, they're trying to weed people out and, survival of the fittest. And I'm like, here is like such a conducive learning environment. They actually care about us as individuals, as people, as a student, as a, family member, as, any role that we, currently function in our lives. You guys actually care. I feel, at least that's how I feel. And I feel like you guys help facilitate, a fantastic learning environment. So I don't feel so pressure to do rather than, I'm actually learning because I don't feel so much pressure about the program and worried about, am I going to get kicked out, or is this going to, cut the, make the cut for this, level of functioning for this, assignment. So I really appreciate, the support that you guys have given us. I'm looking forward to, many more semesters in the program.
Well, thank you for acknowledging that. The thing that we pride ourselves on is the fact that we are DBHs and actually been through the same exact process that you are going through right now. We all have a family. We have jobs, we have all these other obligations, and yet we're trying to achieve what only 1.25% of the world's population do. And you have the intelligence, you have the skills, you have the tenacity to do it. So we're there to help support that because, from your admission to your completion, you're going to be able to reach people that I'm not going to be able to reach in different parts and different, speak to people that I won't be able to speak to and have the impact. So it's really about the mastery of the work. And we take great pride in providing that support to you all, because we remember where we come from. We didn't get in position. And then, then we come so astute when we got things like, no, we have to create a person-centered approach. We all person-centered. Me working at CGI, I'll have to say is the best working environment. This is not because I want to raise or anything like that. I'm not saying that, but it's the best working environment that I ever had.
Well, we understand and we know about the evolution of CGI and its origins and its founders, but it's fairly evident, at least to me, is that you guys, first of all, is very thoughtful and intentional in how the program came together. But what it feels like to me seems like to me is that you guys like working together. You like, working environment is really support. No, that really shows. And to Jennifer's point, the level of accessibility, I just can't even begin to describe it. Literally just the other day, and I'm a co-sign with you, Napoleon. I was accustomed to having until midnight Pacific, 11:59 Pacific Standard Time, and getting an assignment in. Assignment I had to turn in for Bow Down 2, for whatever reason on yesterday was due at 8:59. Yeah, and I was, just going about my business, doing Then when I sometimes it was like 9 o'clock, which typical, like it's a busy life. I was gonna just say, hey, just put it in. I tried to put it in, it wouldn't go in. And it's like, what's going on? I was like, I thought I had to look at it again. I was like, what's going on? What am I doing? I know I'm not technologically as savvy as you, Doc, but I'm saying, what's going on? It occurred to me, I looked at the thing and said, 8:59. I was like, what? And so reached out to Dr. Napier, and she's like, like you said, email. She's like, oh yeah, I'll open it back up for you. You can put it in. No, questions asked. She didn't make me write on the chalkboard 100 times. I will pay attention to the clock. She didn't do that. And I have a chalk ready too. I got a whole box of chalk because right after that, I went out to Walmart and bought a whole big industrial size chalk. I knew this was going to make me do it. I didn't do it. So she didn't make me do it.
Yeah, Dr. Napier is one of a kind. So again, we pride ourselves. And the deal is that, your time is going to come where you're in leadership. And so, like I say in my classes, this is something, a culture that I want you to pass on in your workplaces and different areas is like, remember this. So, definitely, I thank you for acknowledging the environment. Anyone else want to speak to anything about the support?
Yeah, for me, I would just say that it's been from inception with my interview, because I'm gonna just be honest with y'all. I boohoo cried my entire interview for like 10, 15 minutes. And they were like, no, it's fine. And I'm like, mad at myself, why are you crying? Like, this is okay. And so just y'all teach us about being person-centered. And it's not just y'all teaching it, y'all actually walk it like you talk it. And for me, like, I would email Dr. Baldwin and I'm like, okay, this is what's going on. I'm confused. what's happening. And he's like, all right, just jump on a call. Same thing with Dr. Young. Like, everybody has been very accessible, even if it's just to answer a question or call me out and say, okay, you just need to slow down. You're overthinking this. Just calm down. It's not that big of a deal, you know? So that's what I appreciate, because it's like, y'all teach us how to check ourselves as well. So, yeah.
Well, thank you, David. And you've been doing a great job from your inception in. And again, I know your father will be proud of what you're doing. So, and we look forward to you receiving that white coat in a few years and everything. And I definitely know that he's smiling on your work. So he's part of the process. So that's the one to definitely recognize the ancestors and their contributions to what we've done. And anyone else have any more comments on that?
I mentioned to you the other day, a parting shot here, that my first semester I had a class with you and Dr. Young, and I just kind of said that you guys spoiled me. I feel like that couldn't have been a better launching, to have both of you guys kind of get us on the way. That I think, and I'm sure I really, what I said earlier still holds true. I think you guys all like working together. It kind of shows y'all kind of work together as a team. But I don't know, if I feel the same way had I not started out with both of you guys. So kudos to you guys. Kudos to the work that you guys do, the effort that you take and make to make sure that everybody comes along. Yeah, it's really it's a testament to, I think, your guys' commitment and it's the passion that you have for what you do. It shines through. So kudos. Thanks.
Thank you. We will continue being there for our students and be there for one another, where we, like I said, it's a great working environment. So it just matriculates down into the curriculum and is sincere. And Ms. Shadiase just credit my saying, crossing the finish line together. That's a statement. Thank you for raising that up, because that's what it's all about. It's about doing it together. No man is an island, as the song says. And, we will all cross the finish line together successfully. That's the key thing. And I will end this podcast by saying this here. There's a quote, and I just wanted to marinate, and because I want to let each and every last one of you know that I'm definitely proud of you. I'm proud of the work that you're doing. You're representing the DBH, in ways that was only imaginable. But the one thing I want to, as we close this here, I want to leave this statement. And the statement is: there's a quote that says, "We are our ancestors' wildest dream." We cannot not acknowledge, the people that came before us, that were denied access, education, denied rights, denied just treatment as a human being, and as they're trying to figure out how am I going to survive, or how I'm going to, from day to day, what I'm going to do for my family. I got all these things and all these systems and different things against me. We're not thinking about, I'm going to a doctorate program then. But because of them standing in the gap for us, all of us, we have to give acknowledgement to our ancestors. So this is, I want to say, this is a wildest dream. This is the wildest dream. But also with that wildest dream, there's a work that we have to do that only we can do. So I thank you all for participating in this. Thank you for say thank you to your families for allowing you to give this time to us, and on your personal times. And Jennifer, tell the twins I said hello, and I'll see them in class.
I will.
Good stuff. And Napoleon, we got another set of twins. We'll tell them, hey,
I sure will.
Tell them Dr. Uncle Grant's coming. to Detroit.
All right, come visit us.
I'm gonna come. Hey, I'm gonna come today. My goddaughter stays in Ann Arbor.
Okay.
My frat brother's daughter. So that's more reason of me. So we will commune soon.
That'd be awesome.
Hopefully this summer, you know what I'm saying? So we do something. Cause y'all that weather, that cold, I ain't trying to come up. But we'll talk about it another time. Thank you all for the sacrifice. I salute you all.
Thanks.